Good evening to everyone. Good evening.
Emma?
So you have had a tough choice today because you had actually two workshops to choose from, but thank you for staying with us. Thank you for being with us here. And as far as the other event is concerned, you will have a chance to watch the video recording. Thank you for inviting us. So we have looked at the answers, at your answers to our questions, and the impression is that preaching to the choir is something that we do. So, like preaching to the like-minded people. So that's the picture that we got from your answers and your questions. So we have already got our own choir where we can be singing one and the same song. I mean that normally people who are well in the topic do attend our meetings, and these are all like-minded people. So thank you for coming. We will start. We have actually started. I'm Anastasia Lukhina, and I'm the author of the Not a Scary book and the editor-in-chief of the handbook Humanity and Empathy in Healthcare. And we have launched this series of broadcasts within the laboratory of empathy, um, a person, not a disease. We have done it in order to share our experience of implementing the best practices, ensuring empathy in healthcare while working with students and teachers, lecturers of universities. And as you know, over this period of time, starting with spring, we have conducted a number of broadcasts, a number of workshops where we were sharing best practices and best experience. We had the last broadcast with Mrs. Connor from Australia. It was in July, and now I'm very happy to welcome Natalia and Hunar from Sweden. And today we will speak on how they teach medical communication and how they use simulated patients. So, just in brief, let me tell you that we got acquainted with Gunnar in the EACH Association, which is the International Association for Medical Communication that unites experts working in that field. And I'm really happy that Gunnar has kindly agreed to share his experience. And when we were preparing today's discussion, when we discussed how we are going to do this, he said that we've got a great Natalia who has come from Ukraine and she now works in the simulation center. So let's engage her in this workshop. That's why I'm so happy that we have both Hunar and Natalia. Gunnar works as a family doctor and he's been teaching medical communication for quite a period of time. Natalia works in the simulation center. Natalia is from Kharkiv by origin. And when she starts telling the stories about how they arrange it there, she can never be stopped. So I hope that today we will hear about the Swedish experience, the Swedish way of doing this. And I will probably switch to English now.
Okay, so thank you very much for being invited to this session. It's really a great honor to be talking to you all. Um, as somebody else said, I think it was Eva from Ireland. It's really astonishing how you could put a lot of effort into this under the circumstances you live in right now with the war. But we hope this will give you some ideas that you may be able to um, get into action either now or when the war is over.
Just some extra sound, sorry for that.
Okay. Um, so we do live in a different situation in this country. We haven't had a war for 200 years. The last one we had was with Russia also, where they took half the country away from us, which is now Finland. But we're very lucky to have been in peace for a long time. Our university is also very lucky to have started rather recently. So we have sort of no history of very powerful institutions or professors that could be a problem when trying to implement new things into teaching. The University of Linköping started in 1975, and the Faculty of Medicine started in 1986. I shall try to share my presentation. Yeah, just a little briefly about our university. It was, as I said, formed rather recently, and we copied a lot of features from the University of Maastricht in the Netherlands. And at their Faculty of Medicine, they do have a lot of time and space and equipment for communication skills training, and we got that adopted to start off with. So for all those years since 1986, we have had a lot of time, space, and funding for doing communication skills teaching to all our medical students. It may, or it has proven to be more difficult for established universities to get this into their curriculums, but we were lucky to get this from the start. I should also say that if you do have questions, you could sort of put them in the chat right away, and so we could answer them as we go along. You don't have to save answers to the question and answer section afterwards. So the university and the Faculty of Medicine educates doctors and nurses and physiotherapists, occupational therapists, and speech therapists. And there are about 300 medical students per year. It's 6 years studies to become a doctor, 12 semesters, as we call them. The whole tuition is based on problem-based learning. So we have very few sort of lectures like the way we had in the old days, like when I studied medicine. When I studied, you were given a thick textbook of anatomy and were supposed to learn all the bones of the body and all the muscles and where they started and ended and so on. Today, the students are given cases of from real patients that put the light or the focus on something that they're supposed to learn at that stage. And they have a process in tutorial groups where they sort of have brainstorming, trying to figure out what to learn to solve this case. And that's the principles for problem-based learning. The students, as it says here, takes responsibility for their own learning. And they work often in like 2 steps. First, they're giving a scenario and they have to figure out what is our understanding of this scenario now and what do we need to learn to solve this scenario. And then they study for maybe 4 or 5 days, and they gather again and discuss what they have learned and how they go further with this scenario they've been given. So that's the base of all the tuition in medical school here. And we think it's, yep. Well, in each tutorial group, which consists of 6 or 8 students, there is always one facilitator. That is some kind of a doctor. So they do have a facilitator, but that one is not there really to tell them the answers to the case, but to give them hints of how to study or where to find the facts they need to know. But this way, it much easier gets sort of internalized into their memory. I mean, if you do have a problem that you want to solve and you find a solution, then you tend to remember that much better than just studying a book from A to Z. So this is a way of sort of getting real life into tuition from the start. And students do find it a bit tricky to begin with, but after a while, when they get accustomed to the context, they are really happy with PBL, and they do think that they learn much easier how to really make use of their knowledge in their function as becoming a doctor. So we're happy with this model. I don't know if anyone in the Ukraine works with problem-based learning. Again, we stole this idea from Maastricht. The first university in the world to work with PBL was McMaster's University in Canada during the 1960s. And I think it's quite a few of successful learning institutions use this method. Yeah. But there is a lot of literature about it. You can read a lot about problem-based learning. And you're happy. We're happy if we spread the word, because we do think it's easier to get a feeling for what you're going to use your knowledge for when coming out as a doctor, if you have learned it this way. So then crossing over to our communication skills training, in the current curriculum then, communication skills is practiced on most of the 12 semesters in our program. In our model for communication skills, we talk about the patient's part, the doctor's part, and the shared part. And in the preclinical years, that's the first 2.5 years, the students then practice the patient's part and the doctor's part. The first semester they use simulated patients. The following 2 semesters they meet real patients. They go out to health centers around the country and like every 2 weeks and have sessions where they do have encounters with real patients that have come to the health center to see a doctor. And they first meet the students, and then they film their encounters, they videotape them, and then they follow the patient to the real doctor. Afterwards, they have feedback from the doctor on the videotapes they have done before the patient encounter with the doctor. In the clinical years, we practice the shared part, including, well, breaking bad news, difficult encounters, and then we use simulated patients. So it's mostly experiential learning and very little theoretical teaching, very little book reading. We use formative assessment and a portfolio system. So for each conversation that the student has had with the patient, we sort of fill out a paper where we assess their ability to perform the various parts of a consultation. And then we assess whether it's good enough or not. If it's not, then we have a talk with the student about how to improve things for the next time and so on. But we have no real exam in communication skills. So it's, again, a portfolio system where, like every conversation with a patient, is a part of the overall assessment. As I said, we have an emphasis on person-centered care and person-centered consultation. And we think this three-part consultation model is very good for putting that emphasis on person-centered care. So why? Well, of course, there are many models. It's the Calgary-Cambridge, it's the Four Habits model, it's this one. They all they're in the same landscape. They're talking about the same things. They're all aiming at providing a very good conversation with a patient that fulfills the needs of the patient and of the doctor. So there aren't that many differences between them, but as to the Calgary-Cambridge guide, it's rather complicated. It's 72 different items that you're supposed to, maybe use during an interview. This one, the three-part model, is much easier to learn, easier to remember. I think the reason it's been chosen in this country is that the colleague Jan Helge Larsen, Danish researcher and doctor, who sort of proposed this model, has been giving consultation courses to a lot of Scandinavian doctors for many years. And I think that's the reason why it has been so popular here and adopted. But I can see, yeah, it is easier and simpler than the Calgary-Cambridge guide, although it sort of contains the same basic elements. Does that answer to your question? So we just want to ask ourselves, why do we want a person-centered consultation? And many people think it's just because it's nicer. It's nicer to have a nice chat with a patient. But really, the most important thing is that gives a more effective diagnostic process. It's easier to make a proper diagnosis if you have listened really carefully to what the patient thinks and wants. The patient gets seen and listened to, and of course the doctor is able to understand the patient's problem better if we invest a lot of time in the beginning of the consultation, which is the patient's part. What we do want to achieve is then, of course, better health for the patient, and we think a person-centered consultation gives better compliance or adherence, which leads to a better outcome of treatment. It also reduces frustration for both patient and doctor. The frustration for the patient is less because they get listened to, and the frustration for the doctor is less because there are elements in this model that allows us not to start arguing with the patient to begin with. For example, if the patient comes with too many demands in the beginning. If you follow the different steps in this consultation model, then you don't have to get frustrated over arguing with the patient before having made a proper diagnosis and so on. And it's also nicer. So lots of reasons for being person-centered. Yep. No, we can check it now. Hmm. Yeah, as I said to begin with, we were very lucky to start from scratch. As this was sort of built into the teaching from the beginning. Everyone was sort of accepted it, and everyone was eager to start using it already in 1986 when the Faculty of Medicine was started. So I could imagine that if you try to change a traditional university setting into problem-based learning, it is quite tricky because you have to sort of rewrite the whole curriculum, and there are often very sort of powerful mechanisms with powerful institutions and professors that want it the way they always had it. So in our university, there aren't any sort of there isn't an institution for anatomy, for example. The tuition at the medical school is determined from different groups, theme groups. For example, the theme for circulation, which contains both internal medicine around cardiology, around surgery, or other different specialities that sort of work together in that theme group. There's another theme group for metabolism, which also gathers colleagues from different clinics, and there is one theme group for professional development, and the communication skills unit is part of the professional development theme group. So that's a big change if you're used to having one institution for anatomy, one for surgery, one for infection and so on. It has to be, well, to make this uh, sort of PBL work, you have to cooperate between all sorts of specialities. So it's really a rewriting of the whole curriculum to make it happen. So back to the three-part consultation model, which is the one we use then. It does make, well, one of the main features is that it makes a clear distinction between the patient's part and the doctor's part. As it says here, a problem in many consultations is that you're short of time, and as soon as the patient begins talking, the biomedical reflex is awakened in the brain of the doctor, and the doctor starts asking questions and thereby stopping the patient's narrative. And according to research, the doctor interrupts the patients after 23 seconds. But if you let the patient speak, they usually speak no more than 2 minutes. And during the patient's part, you're not allowed, really, if you do it properly, you're not allowed to ask any questions at all, except perhaps what brings you here today. And then it's a matter of shutting up and listening. And one of the things that Jan Helge Larsen suggests is giving the patient a lot of receipts and make small summaries, and avoiding the biomedical reflex, so no direct questions on medical matters. I'll talk more about receipts soon. So in the patient's part, the doctor is listening. It's favorable to be curious of what the patient says. It's like imagining you're talking to a friend who comes and tells you an interesting story, and you're curious to hear this story. That's the mode you're supposed to be in. Not asking questions, not interrupting the patient, but giving receipts and summaries. So before the patient's part is over, you're supposed to know what the patient's ideas, concerns, and expectations are concerning this matter. But we try to teach our students not to directly ask for them, for the ICEs, but instead give the patient a lot of time, say things like, tell me more, and so on. So usually the patient then tells their thoughts, their concerns and expectations by themselves. So receipts, that's verbal acknowledgements. Many doctors just say, and well, that's a way of showing you that you're there. But in this model, we think that having a sentence of this kind is gives much more to the patient and makes the patient tell their story and their concerns much better than just saying, So the receipt could be reflecting, saying, oh dear, that must have been tough. I can see you're concerned. They could be inviting, saying, that sounds really troublesome. Tell me more. They could be confirming, it's really good that you came here today, and thanks for letting me know. Then I know what you want. And normalizing. It's quite common to have those thoughts when you experience such symptoms. That's examples of receipts. And we do try um, to train our students to use um, utterances like this, acknowledgements of as answers to things patients have said. That's what you're supposed to say during the patient's part, apart from then summarizing. You can do several little summarizing things um, during or when the patient speaks, and then sort of end the patient's part with a bit more of summarizing, also summarizing the ideas, concerns, and expectations. So this is the patient's part, which is, well, rather special to this three-part consultation model. And it gives a lot of space for the patient to tell what they come for, what they fear, what they have thought of um, in the days preceding the visit. Well, I do think that we, in our country, usually have more time with each encounter than in other countries. Um, but even in countries where they do have very little time for the consultation, it has been obvious through studies that this way of starting the consultation actually saves time because you get to know multiple things that the patient wants to get done. And usually, if you leave the patient talking, it's not more than 2 minutes. Most patients just talk 2 minutes and then they've covered everything they want you to know. So it isn't, I mean, of course, there are some patients that have a full list of things. And if you feel that this is just going to be too much, then you have um, to say that I see you have lots of things on your agenda. Now we can't cover all that today. So which of all these do you think are most important? But most patients only speak for about 2 minutes, but that's much more than 23 seconds. So anyway, I mean, giving the patient a lot of space in the beginning of the consultation is crucial for the person-centered consultation. The doctor's part, that's the usual stuff. We don't have to talk so much about that. Ask all the necessary medical questions, and they don't need to be open-ended. Um, so this is what doctors do all the time. And then they do a relevant examination of the patient. Then we come to the shared part, which is also a bit special to the three-part consultation model. It starts with the you part, and then we repeat and summarize what was said in the patient's part, including their ideas, concerns, and expectation. So you came here today because you had a back pain since 3 weeks. You had a thought that it might have been caused by your work in the garden, but you also had a concern about that it might be a herniated disc, and you wanted an MRI scan, for example. Because if you don't do that during the doctor's part and the examination, you might have forgotten what the patient wanted, which you learned in the patient's part. And by repeating it now in the beginning of the shared part, the patient sort of gets to know that you still remember that they had that concern and that they wanted this, for example, special X-ray done. So after the you part comes the I part. I have now examined you, and my medical assessment is, for example, this is maybe a herniated disc. We use assessing starting point from the Cambridge Guide. What you know yourself about herniated discs. We make explanations about the condition. Thinking aloud is a very important thing here, that you sort of tell the patient how come you suspect this condition, and you comment on the questions and concerns from the you part. So, for example, if the patient has had concerns about it being something far worse than a herniated disc, you can tell them that I have there are no signs of any malignancy, for example, or my assessment is that this is nothing dangerous, and so on. And also, now you've made a medical assessment, and you can say that in this case, there is no need to do an MRI scan because most herniated discs heal by themselves. So we want to wait for at least 3 months before and see what happens with your back pain. If you still have your back pain in 3 months' time, and it may be possible that we need an operation, then we need to do an MRI scan. So now, when you come to this point, you have sort of more, you can much easier say no to things, or to have a proper shared decision-making talk with the patient than if you had started arguing to begin with when the patient came with those demands. So when the patient comes with the demands in the beginning, you just say, thank you for telling me, then I know what you want. But here in the shared part, you have made your medical assessment, and that's the base for what you recommend. So the we section here is the shared decision part, where we discuss possible solutions, and you recommend things that you think are the best for the patient based on medical assessment and knowledge of best practice. But of course, you have to take the patient's views into account. When discussing and when giving explanations, we also need to be certain that the patient understands. So chunk and check, another thing from the Cambridge Guide, comes in handy here. Just tell them a little bit and then check understanding. And the last is the what. What do we agree on? How do you remember? Could you please tell me what we have agreed on today and what is going to happen, to make sure that the patient has understood and remembers? Because usually, even if we think we're very good at explaining things, patients usually just remember like 50% of what we have said during consultation. So we need techniques for better adherence, like written material, maybe telling the patient that there is a website which describes this, and also security net. If you were to get worse, what would you do? Okay, so this was very fast, going through the 3-part consultation model. The first part was the patient's part, with giving the patient time and space. The doctor's part is the usual one. The shared part focuses on shared decision-making, but also on sort of reminding myself of what the patient wanted to begin with and what concerns they had. so as they get answers to all those things. Right. Well, again, don't start arguing in the patient's part. Thanks for telling me that you expect an MRI scan and really strong painkillers. Then I know what you want. You're able to say no to these things much more efficiently in the shared part. Always use the perspective of what you know is best for the patient in the long run. When saying no to things like sick leave or strong painkillers or whatnot, you may say that I realize that you would want this right now, but I know that in the long run, the best thing for you is not to have a sick leave or best not to take those pills. That's a good motive for saying no to things. And it's also a help for what we call choosing wisely, choosing the right kind of remedy for the condition, choosing the right medication, and so on. Well, I think the focus on the patient's part, which makes it so usable for person-centered care. It's I think the greatest advantage is this the patient's part with which is quite unusual for doctors to learn, not to ask questions. It's very tempting to ask questions as you get all those thoughts about what may be the trouble with the patient. But you have to sort of save all those questions for the until you come to the doctor's part, because otherwise you would stop the patient's narrative if you start asking questions in the patient's part. Well, you have to get all the older boys on this theme. I mean, you can't just teach this to students and to young doctors, because when they come out into real world practice, they will notice that the old boys don't do it this way. So you would need, ideally, to motivate people that have worked there for years to the advantage of communication skills training, for example, so that when students and young doctors come to the reality, they see that it's used there as well. Sure.
Mm. Ja, jag spróbuję.
Yes, let me try to share my screen.
Yeah.
I wonder if you could introduce yourself. How did it come that you started your work with the Simulation Center? I think it's going to be of interest for everyone.
Tak, rozповім. Зараз
Yes, just a moment.
Подивитися тільки, щоб воно так. На весь екран бачите.
Can you see it? Yes, now we see it full screen.
Так. Дякую. Дякую за запрошення. Дуже приємно
Thank you for the invitation.
долучитися та поділитися досвідом.
It's
Я
my
розповім,
pleasure to speak to you and to share my experience.
я розповім трошки про мене. Я у Швеції 3,5
Let me
роки.
tell a couple words about myself. I've been staying in Sweden for 3.5 years.
Так, ми переїхали з війни, з Харкова.
We moved from Kharkiv.
Навчалася я в
Natalia, you can speak because we do have simultaneous interpretation, so you don't need to make pauses.
освіта в
Don't
мене
make those pauses, please.
Дякую. Освіта в
Yes,
мене з
thank you.
Харківського університету
So, I
біомедицинського.
got my education in Kharkiv University in biomedicine.
Працювала я 12 років в медичному
I
закладі.
worked for 15 years in a healthcare institution
Обласна лікарня.
in the
Де я
regional
працювала
hospital.
10 років, де я працювала 10
I
років
worked there for 10 years
біомедичним інженером і 2 останніх роки фахівцем з публічних
and
закупівель.
for 2 more years I worked as a public procurement expert.
Після війни, як розпочалася війна, приїхали до Швеції за 3 місяці.
Then I moved to Sweden and I heard to learn Swedish for within 3 months.
Перший рік як персональний асистент для хворих людей, щоб якось...
Then I worked for the first year as a personal assistant for the people who were sick.
Але не полишала надії знайти роботу.
But I still hope to find a job that would be closer to my competence.
Університету, до клінікуму, де працюю зараз як
And in that way I got to the clinicum where I work highly intensive now.
Також у симулінгах, у симуляціях. Працюю з
I work with
ресурсами.
simulations, with resources, with simulated patients.
Тобто дуже цікаво, дуже багато нового. Та розкажу вам про наш навчальний
A lot of
центр.
new things. And let me tell you about our clinicum.
Клінікум називається на медичному факультеті, де студенти медики
At the Faculty of Medicine, where we have medical students.
Практичним навичкам.
Well, Natalia, let me tell a couple of words about you. So, on the one hand, Natalia is servicing all the technical parts of the simulation center, like dealing with blood, checking the fitness of rooms, but sometimes she also access the simulated patients. So, she has shared a story. Let me introduce this story. So she told me how she was invited to work as a simulated patient, and students were told how to work with a person who speaks with a sign language, who doesn't speak the language that you have a command of. So we spent about an hour speaking over the phone, and Natalia shared so many stories. Therefore, I really feel sorry that we have this technical issue, but let's hope that the problem has already been fixed, and Natalia is going to tell us about this herself. And Natalia, are you here? Yes, great. And by the way, we can hear you much better now. Yes, sorry for that. So let me go on. Let me speak about our clinicum, about our skills lab, and the patients who are getting their practical skills here. So, for each campus in the University of Linköping, at all campuses, we do practice this. First, we have it for medical nursing, starting with measuring the blood pressure up to installing catheters. And they are trained how to do injections, and all the resources that are there are procured by us, are produced by us, and students have a very good growth environment. We have trainings in the clinicum. They could be the ones Gunnar has told you about. So these are communication ones, like meetings with simulated patients. We may also have some students working in groups. another sort of training. This is group work. Different professions get together, and let's say they have to take some resuscitation measures. And in such cases, in all those simulations, we're also using mannequins, kind of dolls, that have very good technical equipment, and also a tablet is provided, and remote control is added. And teachers actually do set the parameters, and the students working in a group have to quickly respond and to work in a stressful situation to learn how to do it in stress. They need to delegate and to share the duties, decide who is responsible for what. And they work not only with simulation devices, but they also work with simulated patients. They have a heart attack to work on. They have some resuscitation measures that they need to uh, do in a well-structured way. They need to also take the history. Then if a patient has not fainted, then they need to ask patients for data. Otherwise, their first steps will be different. Like other HCPs find some other solutions, but communication in all those situations is the most important thing. They also learn how to get oriented about a situation, which is also important. And simulated patients are medical students, and throughout the whole study, like in the sixth, and the first, the fourth, the sixth, and the ninth, and the 11th semesters, they have this communication training. Well, first, it looks like just a meeting with the patient where they ask simple questions and build rapport. And then during the second and third semesters, patients have some practice of working with real patients, and they get back to the clinicum. And in the fourth, in the sixth semesters, they already work with those simulations that are called stream here in the clinicum. And they have to use scenarios within which they develop um, their communication with the patients. These patients are already concerned, anxious. These are problem patients. They are patients in stress, and they need to build rapport, to do history taking, to do the examination of the person who strips off the clothes. So all these things um, need require from you some patience, some empathy. So here students are developing all the skills the doctor needs to grow, and they stay in that environment throughout their study period, which is really, really important. The scenarios of the first semesters are simple, then they get more and more complicated scenarios, and in the last semester, these could be breaking bad news or death news about the death of the relative. How do you explain it to the relatives? Um, then they need to work with patients who have strong emotions, like people who are addicts. So scenarios could be different. We have also got consultative simulations with interpreters, and I myself was involved in such simulations twice. I was a simulated patient twice who spoke Ukrainian with Swedish doctors in trying to explain everything using the interpreter services. So you have to explain all about yourself to the doctor who is supposed to do history taking, and the doctor needs to ask you exactly the right questions for you to be able to share your information. He needs to calm you down, and he needs to help you share all the information in spite of the fact that there is an interpreter. And doctors in such contexts also need to pay attention to the personality. to an individual, because if the person feels safe, he will share more important information. And more important information is something that doctors need to give the right recommendations in a specific situation. So this is really important. Well, so I've tried it myself. I've got this experience. As far as those communication skills trainings, or the trainings where we use simulation devices, take place in a safe environment. I mean, no patients are affected. And any problems, any hardships that pop up during those trainings are always discussed in the right time. There is also self-reflection after every single phase, and there is always a scheme for every single training with the logistic steps well prescribed. And suppose you have a complex scenario with a complex simulation, then they may include resuscitation measures before or during a heart attack. So there is a patient who shows that he seemingly has a pain in the breast. He plays this role and shows this pain, and the student needs to do some resuscitation, and then the diagnosis is set, a person stays under treatment, and students from different professions, medical nurses and doctors, get together and they respond to this scenario and help whenever they are most competent, with what they are most competent. And they develop their communication skills through communicating with each other. So they also understand much better what duties other students of other professions have. Communication trainings and stream trainings over all the semesters are video recorded, and the lecturer can also, the facilitator in fact, can also give his feedback. He may discuss like what the hardships were, what any special needs were, what could be changed for the better. So all the things are discussed, and the students get uh, feedback from the facilitator. Students also get feedback from their peers staying in the same room. So this is a mutually enriching environment where a person gets accustomed to having someone who will provide feedback. And a person it gets accustomed to asking well-structured questions. But in that environment, we have attention to individuals, we have empathy, we have feedback. Let me go over to my next slide, if everything works well. So in our clinicum, we have 94 simulated patients. These are our staff members, the workers of the university of different age. These are young people, these are volunteers, these are elderly people, but these are well-trained people. So these are the ones who probably have some experience of acting out, the people who are willing to try their hand in something. So these are highly motivated people, mostly the people who have retired. And over the recent years, the number of young simulated patients has also been on the rise, because some of the diseases are getting younger. That's why it's necessary to also engage young simulated patients. So a lot of our staff workers are willing to be engaged in that range of simulated patients. The selection takes place 1 or 2 times a year. This is recruitment actually. And letters are sent, people get together, all their duties are described. And we are telling them what the possible hardships could be and what it generally looks like. Then we have a drama training 4 times per year. These are trainings in the format of workshops where you can meet a teacher who has been hired by the university. And this is a training where those simulated patients are trained to show some strong emotions or to show some receipts, like symbolize some pain, signal actually some pain or anxiety or concern, or they are also trained some other things that could be a part of the simulation scenario. Simulated patients are also expected to give feedback to students in their role, because they may also think that at a certain point in time, the student should have asked a better question, a more polite question, or probably he showed some strong emotions and the person didn't notice this, or just didn't notice some other important thing about the behavior of the patient. So it's also important for the student to get feedback from simulated patients to improve further on. They should not act as teachers. The salaries of simulated patients is about 15 euros per hour. And in every campus in Kligam where we have such trainings, we have a computer with the system for registration of the hours that these people work. So this is pay hour, an hour pay. So we help them to count the hours. Every software, every program for medical nursing or for doctors get the funding from this overall fund. And you know, we have to ask you what the budget is. We are Ukrainians, so he said he is asking what the overall budget, annual budget for those 94 simulated patients is. We are Ukrainians. We are always willing to learn the information about the budget. Unfortunately, cannot give you an accurate figure, but that is not a lot. That could be like 3 hours, 3 times a month per patient who um, is engaged in the simulation of a heart attack. We have to work all day long, and normally simulations last for about 3 hours, starting with the study of the scenario and up to the point in time where students work in a group for some 2 hours, or when they work alone. But the patients who work for an hour, well, for a whole day, these only for heart attack simulations. I cannot tell you what the exact amounts are, but if we lack money, then we close this or that part of these trainings. But we actually working on having more of them, because we need to have simulated patients for occupational therapists. Every doctor in every specialization needs to develop communication skills in order to improve the process. But of course, sometimes we have some budget constraints and we have to reduce the number of simulated patients in some areas. So the University of Linköping was actually the founder of those large simulation courses with simulation devices, which cost quite a lot. They are really expensive. And this resource is used as resuscitation measures. And let me tell you the following. Let's say in the study center, in the training center, we have 4 different rooms and 4 different situations. A girl with the anaphylactic shock, then a boy who came from a restaurant with hypoglycemia, fainted, or a man with pain in the breast, in the chest. So they have to enter the room to learn the group students, they need to set the diagnosis, to learn what the reason behind that is, at least to make an assumption. Then they need to show how they work together, because always, well, this room is always split. There is a window and there are observers. This is also a group of students observing what they do, and then they can give some feedback. In an hour's time, they make a swap, and those who used to be students working with simulated patients move out and start observing the whole process, and they can also give some feedback to those who then started working inside the room because um, there could be different signals, sounds, noises, like a child crying or somebody from the relatives is staying and crying out, saying help, asking for something persistently because people are in stress. So somebody also needs to go and calm down these people. So the observers watch whether they really did it in the right way. There should be some people who work with medical aid, and there should be some people working with the relatives and extra noises and extra things. So it's important to have it all done in a well coordinated way. This simulation of stressful situation is something that they work on during the 11th and the 12th semesters in the 6th year of studies. Natalia, and here is another question. Actually, we do have two questions in the chat. Could you speak more on how simulated patients are trained? Because you mentioned that they should have some acting skills, but there is also a component of feedback provision. So, do you train your patients on that? Could you please tell us a little bit more about that? How are they trained to be simulated patients, and what is the structure of this role? And here is another question coming from Serhi. Who and how develops and coordinates those simulated scenarios? And how many of such simulation scenarios do you now have in your possession? All the scenarios are developed by 7 groups. Huna actually said the SIM group, I'm sorry. So this is the group that actually determines which situations are more relevant, which are more difficult for responding, and in which ones we need more training. So those simulated patients, before they get some simulation scenario, will and before they start acting out, they go through that scenario. And there is also a drama training, as mentioned by me, where they train together with the teacher how they are supposed to do it. This all depends on the scenarios. And at the end of their learning process, they have to work with more difficult diagnoses. They have to work with breaking bad news, some more difficult situations, or they have to work with people who abuse, who are addicts, or a person gets. They have to work with a person who gets the news about an oncology diagnosis or a loss of close relatives. So we work with such scenarios as well, and there may be two different reactions. The person may just freeze, and you have to some communicate, or there can be a person who is in aggression, who shows some strong emotions. So they have this training. They read a lot. They are trained, and we actually don't have too many scenarios. I would say that we have about 18 in the 9th semester where they really work on those communication skills. We have 18 scenarios. And those simulations with those 4 rooms which I described, this is one simulation for all students. That is a very positive idea because there shouldn't be that many of them, but all students have to go through those simulation scenarios. That's why we also engage our students in the activity in our simulation center. They never cover one and the same scenario twice, but they cover all the scenarios once. So for the introduction stage, they don't have too many scenarios, just several of them, and then they have more. In the ninth semester, they have most of the scenarios because then we focus on their communication skills. And then they have this 1 day long simulation with a heart attack or a brain stroke. And there could be like intensive care unit for the first day. Then on the third day, they check how a person feels, and then day 7 and day 21, because these are the days by which you can check how the person feels. Like day 21, it's already the day when they work in the room which looks like home. So students go there, they see some changes, they respond to that. The person already speaks. The person is not that sick, but he needs some assistance, and it is not the intensive care unit doctor who has to respond, but the occupational therapist has to respond, because he needs to teach the person to walk again and to deal with home chores. Okay, any other question from the forum? So do you see any negative sides to the use of simulations and simulated patients? In particular, maybe you can see some risks we should be well aware of. No, actually, I don't. Because um, these are well prepared people. Nobody works with real patients, so everyone is responsible in about that. Everybody learns how to be responsible about all this, and this is something patients do after they have already had contact with real patients in the second and third semesters. And simulated patients, after every simulation, have a meeting with students to give some feedback, but they also show that they are not sick, that they were just acting their role, and they always give the keywords that keep motivating students to excel. So I don't think that there are any risks behind that. I think that this is only for the good, because the more trainings we have, the clearer the structure of your work becomes, the more habitual it becomes for you to work like this, the better it is. These people are becoming professionals, and they don't need that much time to adjust to real work, real time work in clinics. Yes, thank you. You actually know how people are getting their medical education in Ukraine, and we have just seen how it takes place in Sweden. So if you compare those two contexts, what do you think we could probably start with, and how could we actually grow up such approaches in the Ukrainian context? So what do we start with? Because now in the room we have many people working in medical universities. So how would you do it? How would you get down to all this by already knowing this from the inside? Well, the range of trainings is very wide, starting with VIP communication skills up to those simulations. But there are pilot projects, and that is a good resource. You can try to create some groups with motivated people, with doctors in hospitals or in medical universities. These could be groups of motivated people who will have those trainings and show how it works. I think that at the moment, Ukrainians are the most motivated nations in the world, and we are motivated to reaching positive changes. And if we see that those positive changes are coming, many people will join in the process. So you just need to try it out to show by having a pilot project, by developing several scenarios. Of course, the scenario should be adapted to the Ukrainian culture, to the Ukrainian reality. depending on what is most really relevant for people, what diseases people mostly have. So you need to adjust something, but you can take the same structure from what is already available in the world and somehow adjust it to the Ukrainian realities. That's my point. And I hope that this will really happen very soon. Thank you, Natalia. So we are reaching the end of our today's meeting, and let me try to sum it all up, because we always hear how important it is to sum everything up in a short form, and this is important to do this in the process. So let me try to sum up what we've been talking about today. So we started our talk with Gunnar, and we started with the history of the Faculty of Medicine at his university, how they started using problem-oriented teaching from the start. And one of the key messages here was transition. I'm just thinking maybe I should actually do it in English because all my notes are in English. So this is experiential learning, learning based on your experience instead of some theoretical teaching. It seems to me that this is something that should be in the focus of our attention. How do we switch from theory and books to practice? Then Gunnar also told us that they decided to use a little bit simpler model, which is a three-part consulting or counseling model. And he stated that the use of communication skills and the structure of consultation is important not just for aesthetic purposes, but it's really important to achieve better performance and better results, to set a better diagnosis and to be more effective. I was also what I also liked about in the story of the problem-oriented learning, how many contexts, horizontal contexts you need to create with professionals from other departments and other units, and how careful you should be in developing this collaboration between different teachers for you to be able to develop those scenarios and to work with them and assess them and assess student performance. And Gunnar also dived deeper into the history of the tools that he's using within the three-part model. And I particularly liked this statement that you mentioned about giving receipts in the form of aha or not. So what should our feedback be? There should be some receipts, some reactions. That's what something Hunar stressed. But it's a great shift for a doctor to move, to switch actually from a person who is just broadcasting and saying something to a person who listens and who sums up what the patient says. One of the key messages, as it seems to me, in Hunar's presentation was the fact that, in spite of the fact that the use of the communications model and the structure is quite resourceful and intense in terms of resources, but it helps the doctor to better understand with what expectations the patient has come. And Hunar also stated that it's important to introduce problem-oriented learning. And with this in view, it's important to build this support from the inside with the old guys having different experience, whom you should motivate for you to have support and for students to be getting good experience. Then we switched over to Natalia, and Natalia told us more about working with simulated patients. And here I was impressed by the fact that students get a mix of experience with real patients, with simulated patients, and lessons learned in working with one category of patients is also used by them in working with different categories. So I found it interesting that working with real patients makes them better prepared for working with simulated patients. So it seems to me that it should be vice versa. That's our stereotype, that first simulated patients should come and then real patients, but it's not so. And I also heard that while working with simulated patients, it's important to train the skills for it to become habitual for you. It's like for sportsmen who should make those skills automatic. But also, while working with simulated patients, there is a specific structure you have to follow. It's not chaotic work, and a lot of videos are used to structure everything in a proper way. And as far as I've understood, feedback here is also a very important component because it was mentioned both by Honor and by Natalia. And the last thing to be mentioned by me is that most probably less is more. We should follow this principle, and there shouldn't be that many scenarios. The main thing is to have high quality scenarios and to use those scenarios for evaluation, but also for development and growth of people. And it seems to me that Gunnar also stated that there should be feedback. He mentioned this portfolio system. So you should be collecting those skills into the portfolio of your competences step by step. I hope that I've managed to kind of summarize the key messages of the two presentations. Thanks a lot for sharing your experience. Thank you for inspiring us. I don't know whether Natalia is open for questions, but suppose you have questions, write to me. And I will further those questions to Hunar and to Natalia. I will ask them to help us by giving answers to questions because today I can see you were a little bit shy with asking questions, but maybe questions are still coming for the written part. So I will probably announce that by the end of the year we have several more sessions planned. One of them with Peter Pipe. We will have a talk on the interprofessional communications and collaboration. So how do we teach that? Because he works in Belgium and he will speak on how they integrate learning, how they build this collaboration with different professionals. Then in November we will have a broadcast with Orith, whom you already know. And since we speak a lot about reflection and self-reflection, I've asked her to tell us a little bit more about how she uses it as a tool. And in December, we will have a talk with a German professor who has really done a lot to change educational curricula in Germany for them to be more patient-oriented, and how she could, how it would be better, how it would be possible to add more of communication skills there. So we'll speak about education, academic communication, and help us of changing the university context. So thank you for being with us. Thank you for asking questions in advance. We are waiting for your forms, and we really try to structure those broadcasts following your questions. Thank you, Hunar. Thank you, Natalia. Thanks a lot to all those who have been present. See you soon. Bye. Because we have to finish in time. So goodbye. Thank you. Have a nice evening. Stay safe. Thank you. Goodbye. Thank you. It has been really interesting. Thank you.